right, let's move across now to the big story that we're tracking this evening, which is the Sero studies. Now, you've been hearing possibly of a number of Sero studies which have been conducted over states. First of all, what is a Sero study? Essentially, it's a study conducted by a government body, usually a local authority, to determine how much of the population already has COVID-19 antibodies, which effectively means that's the number of people possibly that were infected by COVID-19, seem to have healed, stayed asymptomatic, and now have developed antibodies for COVID-19. The reason that governments do it across the world is to give an idea, first of all, of how widely the infection has spread, and secondly, to calculate the actual percentage of fatalities, the number of people who are really dying. Now, the ICMR was a nationwide study. This is the first one. They're already conducting a second, and this one was conducted in early May. So the numbers in that sense are dated. But here's the important bit. The numbers show that about 64 lakh people possibly had COVID-19 in early May. Remember, our official detected case figures today is 45 lakhs. At that time, for every one identified case or detected case, there were 82 to 130 undetected cases. So even though testing has improved much more right now, imagine the multiplier effect of how many people have actually been infected with COVID-19. The study also found a higher incidence of COVID-19 antibodies in rural areas compared to urban areas. Now let's go across to our panel to understand more about the importance of these studies. I'm joined today by Bhaskar Katamneni, who is the Commissioner of Health and Family Welfare of Andhra Pradesh. I remember Andhra Pradesh put out its Sero studies results just yesterday. They found about 20% of the population had antibodies. I'm also joined by A Velumani, Chairman and CEO and Managing Director of Thyrocare Technologies, Chairman now of Thyrocare Technologies. Welcome to both of you, and thank you for speaking with us. Mr. Bhaskar, can you begin by just taking us through the whole process of these Sero studies, the one conducted in Andhra Pradesh, and what it has really shown?
Good evening. Sero surveillance, as you had indicated, basically is done to understand the prevalence of infection and what proportion of the population actually has antibodies to the virus. So we did this in the month of August. It was done in 2 phases. 4 districts we did it in the second week, and on the last week we did for another 9 districts. We have a total of 13 districts in the state. We completed for all the 13 districts fairly large size of sample. 5,000 samples in each of the districts were done in the second phase. So overall, the sample size was somewhere near 60,000. And a large sample size was taken, and then the samples were taken proportionate to the population, how it resides in the urban, rural, and gender also as per the population ratio, gender-wise. And we also have maintained the population ratio as per people in the containment clusters and outside containment clusters, and people who are susceptible and people who are not susceptible. So all those parameters were taken into consideration and the Sero surveillance was done. The results were compiled, and overall state has a prevalence of 19.7, that is close to 20%. So that is what the indication comes, but there are variations between districts. So we have districts where the prevalence is as high as 30%, and we have districts where the prevalence is as low as 88%. So what it would mean that there are certain districts which have peaked and would definitely be coming down, and there are some districts which are at a phase where they will be having some more cases coming in a large number. So we use these findings to plan for our infrastructure and for our testing also. It basically means that where the prevalence is low, where we expect more cases to come. Yes. Yes, please.
So Mr. Bhaskar, that's what I was coming to. As a policy maker, you mentioned that this helps you figure out where to, sort of ramp up testing and other such infrastructure, etc. Does it also indicate that more people, very simply put for our audience, more people may have been infected by coronavirus than was previously thought, and a lot of these people may have gone through this whole process without even realizing and have developed antibodies?
This is quite natural. Any good epidemiologist would indicate the same. Number of people that we actually find out were positive, there will be some more people whom we would never know unless these kind of zero surveillance studies are done. And that is quite common across the world. And this is part of the practice that it is done. So, in fact, we tested the most. In fact, I would say that Andhra Pradesh per million today among all the states has tested the most. In fact, it is, I think, more than double the country's average. We are averaging around 80,000 tests per million. Though we have tested more, there are definitely large number of people because we tested mostly people who are primary and secondary contacts of a laboratory confirmed positive person. And we also tested people who had symptoms. And zero surveillance, we don't touch people who have already tested. Zero surveillance is about testing those people who have never been tested and who have never shown symptoms. As you can see, around about 99, close to 99% of the people whom we found had antibodies never had any symptoms, not even the slightest hint of having the virus was what was seen in these people. So that is what it is all about. So we generally focus on people with symptoms. We also focus on people without symptoms who have been in contact with people who are positive. So definitely there would be a gap, and that is common across the world, any country, any place.
Yeah. Mr. Velumani, I want to understand the importance of this because, is it necessary at this point, or is it crucial at this point that we have a clearer picture of how many people have already developed antibodies? It will help us in the process of unlocking, it will help us in the process of moving forward.
Yeah, we are groping in the dark. We don't know where is the milestone of this journey of COVID, whether we have crossed 10% only or whether we have crossed 60%, we don't know. Having said that, the 4,67,000 investigations we have done so far in the country very clearly reveals we have a 27% people having antibodies. Believe me, Delhi was the first reported highest antibody. Today it is not the first because antibodies also die off. As of today, what stands highest is Bihar, where we have done around 47,000 with 31%, and Andhra Pradesh 22,000 tests we have done, that is also 31%. So if you look at countrywide, it is 24%, 27% positive, which means there is a likelihood 40% got exposed. And if 40% got exposed and we have lost only 80,000 people, it looks like we have crossed the journey with the least mortality. So this is my positive way of looking at it. I take a lot of assumptions in it, rural, urban included, metros and other small towns included. Women have better immunity than men. Age-wise, there is no difference. But I must tell you, the numbers which I see in seropositivity study by a private lab without any bias, I have no point to prove. I am very clear that we are 40% clear and we have lost only 80,000 people. So the tunnel seems to be close by, and the light is seen in the end of the tunnel. In my opinion, this 1,000 deaths per day will continue, and we must titrate unlocking, not to allow more than 1,000. And by December, we should be out of it. Tamanna, it is a very positive way of looking at it. Lot of assumptions in it. I only hope what I believe is right.
Now, what I want to understand is also why looking at this kind of data is important, Mr. Velumani, because right now it seems like a lot of despair. You're obviously trying to put a positive spin in it, but the world is trying to fight COVID-19. There are a number of countries that have managed to flatten the curve. India is still struggling, and we've been talking about how this is because of our high density of population, etc., etc. Could this have worked to our favor? Because if you look at this ICMR Sero study, and this is in May, when the migration was still happening, and it shows nearly 70% of seropositivity in rural areas. Right now, we're in the dark, like you said, wondering what is happening with the spread of infection in rural areas. So what does this tell us?
I must tell you here, this is again the positive way of looking at it. If 100 get exposed, 1 get infected. If 100 get infected, only 1 gets into hospital. And if 100 gets into hospital, 5 die, remaining 95 come back. Trust me, with only 60 deaths per million, India has managed, not because of political will or a lot of lockdowns. It is because India is an young country and lot of factors have contributed for this low death per million. So I am of that opinion. This virus moves fast, infects a lot. Don't count the infected and panic people. Look at the number of deaths. We have, with the 1.38 billion population, we have still not crossed 1,000 per day. So that is a positive way of looking at it. We need to look at how to unlock and how not to lose too many lives. If you don't balance, you will not be able to get the economy back, and you probably will be delaying this too long. And what was supposed to be acute, we are making an acute and chronic both by delaying too much. So my positive thinking says, unlock it phase by phase. If it exceeds 1,000 per day, control it. If it doesn't exceed 1,000 per day, keep continuing.
Mr. Bhaskar, what is your view on this sort of school of thought that these sero studies actually give us an opportunity to unlock further? And like I said earlier, as a policy maker, what are the challenges that you are finding on ground?
The data from sero surveillance as an administrator, I look at it in 2 ways. One, the districts and the sub-districts where the sero prevalence is low are the places where I need to be focusing more on improving my infrastructure of testing. I would be testing more there in coming days. And these are the places where I would also be ramping up my hospital infrastructure, more beds, more doctors and all, because the prevalence is low. So there is a chance that in the future, the cases may go up there, and rebalance with the areas or districts where there are districts with 30% prevalence, where definitely any epidemiologist would tell me that in the coming days, the number of new cases that will be added will be lower than the places where the sero prevalence is low. Where it is low, definitely there are going to be a little bit of more new cases coming in. So I will be balancing my both the testing as well as treatment infrastructure in terms of both physical infrastructure as well as human resources, because physical infrastructures definitely can be ramped up, but human resources anyway, there will be a little bit of constraint. So we will be balancing out our HR resources here and there, ensuring that the optimum utilization of resources are there. That is what will be my takeaway from the entire sero surveillance data.
Yes, but what about the question of unlocking perhaps faster that Mr. Velumani was also talking about? That sero studies, in a sense, give us an idea that a lot more people have immunity than we have thought about. Are government bodies thinking in the direction of herd immunity? Is this kind of data encouraging to unlock further?
After unlock 4, I think anyway most of the economic activities were unlocked with the exception of activities in the containment clusters. And containment clusters will continue to be tightly monitored. That will continue. Whatever will the zero prevalence numbers are there, because containment clusters need to be taken in a very different way. The management, there is a different protocol for the same, and that will continue to be operational. So I don't think, and anyway, this data pertains to one state, and I look after one state. I wouldn't be, I shouldn't be talking about the entire country and the policy for the entire country as a whole, because I think there are more learned people and people who are better than me to take care of national level.
Fair enough. No, fair enough. I mean, Mr. Bhaskar, I mean, as a policy maker, as someone who contributes to these decisions, I want to understand the thinking of what this really means. I'm not asking you to comment specifically on what the government of Andhra Pradesh should do or what the government of India should do or what any state should do. But does it point to the direction that more people have developed antibodies than we know? Does it then tell you that perhaps it's safer to unlock more? Because you will agree that the restrictions right now have not really helped. The numbers are still growing and the economic peril is also growing.
Yeah, as I said, see, I would be commenting only on the results of serosurveillance. Serosurveillance indicates that around 20% of population in my state had infection and they have developed antibodies to the same. So it would only give me an indication of how to use my resources effectively. And as I've indicated to you already, the containment clusters, even after unlock 4, the containment clusters continue to be governed in the same way they were during the lockdown number 1. So lockdown number 1 to unlock 4, the management of containment clusters remain the same. Activity in containment clusters remains to be totally tightly closed, no ingress, no egress, except for medical and emergency services will continue to be there as long as positive cases are there. So that policy has never changed. That will continue to be there. That is the way we'll be continuing to ensure that infection doesn't spread too wide, that our hospital infrastructure is not able to take care of it. So the entire thing, what I look at it is that the effort has been to ensure that our hospital infrastructure is able to take care of that number of patients that are coming in without opening it too much, opening it slowly, so that our system also gears up to a level. I'll give an example. When the first COVID case came into the state, the number of beds with oxygen in the state were only 3,400. I wouldn't be in a position to take care of any patient more than 3,400 on that day. If we had let everything open and 30,000 cases come in one day, we wouldn't have been able to take care of those cases at that point of time. Today, I have 35,000 capacity of oxygen beds to treat and some more beds without oxygen. Today, I can take care of more people even if the cases come in. The strategy is always that why a slow letting down has happened is to improve our infrastructure, improve our human resources so that we are in a position to cater to those many people coming in. If I have infrastructure for 3,000 and 30,000 people are getting infected and coming into the hospital, I can't take care of them on that day. So the kind of ramping up of infrastructure has happened, at least in my state. In fact, what has not been done in 10 years has been done in a matter of 4-5 months in terms of oxygen infrastructure, ICU, ventilators. We just had 400 ventilators. Today I have 6,000 ventilators. So that's the kind of phenomenal increase in infrastructure that has happened. So we are able to take care of these patients today, and that definitely I think had resulted in such lower mortality rates. Also, I also agree that being the young demography that we have, people, other panelists, I agree, the kind of age groups we have and all definitely has a role to play.
Yes.
But clinical management also had a definite role, because so our mortality today is what we measure as a number of people who are positive, and ultimately people who have succumbed is somewhere like 0.7, which is far lower than any comparable countries that we have. So the entire logic of lock, unlock was always.
No, but it's also telling us. I agree with you, Mr. Bhaskar. But it's also telling us that we are perhaps just not testing enough. We do not know the entire quantum of how far this infection has spread. We perhaps, are we even clocking the deaths correctly is a question that has also been raised. Dr. Velumani, I want to come to you specifically on Maharashtra and Mumbai, because Maharashtra is still topping the list of states which are most infected. In your view, what are we doing here? Because there are tight measures as well. It's not unlocked as much as the rest of the country because the numbers are high and the numbers keep growing. Where do you think the issue lies?
It is not that Maharashtra virus is more wild or less wild. Virus hasn't reached to some states still. In Mumbai, Pune, kind of metro cities, there has been a huge brunt. But having said that, if all state administrators are listening, we are safe. We have not become Italy. That was the reason why in the last week of March we closed down mercilessly. Today we are not seeing more than 1,000 deaths in the country. We must keep a 20% redundancy in oxygenated beds and ventilated beds, and keep that number that way, and keep on unlocking step by step, step by step. In my personal opinion, 1,000 deaths per day will continue for 100 more days, and in 100 days, you create a calibrated unlocking in such a way by 100th day, you are 100% completely unlocked, and your number then only will go down without getting immunity. If you expect everything to die off, you are dreaming unnecessarily too much. We don't have a vaccine around. We don't have a drug around. Only hope is herd immunity. And the more you keep locked down, the less will be the herd immunity. So you are fighting, but you are actually telling you are fighting, but you are not fighting. So my mind says balance between unlocking and the hospital beds, and you titrate it. By end of 100th day, India would have been literally out of this peak of 100 deaths per day, coming down to 100 deaths per day. We have no choice. I'm talking from scientist point of view, from the way in which the virus is dealing the human being. We are not controlling virus, and we can't control the virus. If we are controlling, we are delaying the outcome. We are only delaying, we are not controlling.
But Dr. Velumani, how can any state government or any central government risk trying to create herd immunity at the cost of people's lives? What you're saying is optimistic. You're saying 100 days more, and then we might see the back of this kind of pain. But it is also risky, isn't it?
Tamanna, it had the virus not come, you are right, the virus has come. For a person who loses his life, his everything is gone. For a person who loses one member in the family, it is a great loss. But for a country of 1.38 billion population, 80,000 people are dead, and we are sitting and crying. Sorry to tell that. The panic levels are so high, we have screwed up completely the economy, to the livelihood. We can't डर के थोड़ी आगे बढ़ सकता है. There is no way. You can't wait for a vaccine because every vaccine seems to be having delays. Drug is not coming around. So there is no way. If you want to delay school colleges, you delay up to April next year. Or if you are safe enough, open in January next year. But you can go step by step. First start industries, first start opening up every job opportunity. Without job opportunity, where are you going to see the hunger being eradicated? It's too bad today. Many don't understand.
Well, some very, very harsh decisions there that people need to make, that administrators need to make. I think from nearly day one of the lockdown, this has been the question, hasn't it? Lives or livelihood? What do you choose? We did a lockdown, we're seeing the economic brunt of it, and yet we have very high numbers. Now we know that those numbers could actually be higher and we could be moving towards herd immunity. We'll have to wait and see if all of this data leads to any policy action at the end of it. I want to thank both of you for joining us on this story.